I thank you very much, Torvik, and thank you very much for the Innovation Agency for the invitation to speak tonight. Certainly, you know, the scale of the problem is for us all to know. There's, like Torvik's mentioned, there's so much preventable disease out there, and the patients that already have got the secondary prevention in place, I think it's important that we emphasize to those patients, you know, they need to carry on with their statins, because there is the risk of revascularization, and all the good work that Torvik and his colleagues are doing with the stents and in the interventions, that all of those could be undone through patients not taking their statins and potentially stopping it because of misinformation. Certainly from our point of view, from a primary care perspective, there is so much that we can be doing in terms of optimizing patients' statin therapy, the lipid-lowering therapy in general, and having those discussions with our patients, and potentially misspelling some of these myths. Certainly LDL-C cholesterol, non-HDL is the big sort of target that we're aiming for particularly reducing the risk of cardiovascular disease. Certainly NICE and the people at QOF thinks that statins are our friends. This is the new QOF indicators for this year, 23-24, and it's worth a significant amount of QOF points for the audience living working in primary care. There are two of these quality indicators. The first one is for patients on the coronary artery disease registers, peripheral artery, the stroke register, the CKD registers. How many of those patients are currently prescribed a statin or is not suited for a statin, or didn't tolerate it? The second one is then those patients that actually have a non-HDL cholesterol levels in the previous 12 months that is less than 2.5, or where there's not a recording, there must be an LDL-C level of less than 1.8. So not only are they saying prescribe a statin, they're actually saying optimize it and make sure that we actually get the benefit of these medications. In many ways, I think I wonder whether they've gone far enough, and this might be a bit of a controversy, whether we should look at primary prevention as well, but that might be something for the future to prevent us getting to this stage. But certainly, I think this is a step in the right way in improving outcomes. Certainly the main risk development is the Q-risk-2 and the Q-risk-3, and those of you that use EMAs will be aware of the whole discussion about the availability for the Q-risk calculation, which thankfully is now staying a little bit longer, and certainly using that for patients up to it's validated for up to 84 years. Like Torvik was just saying, these patients still need to be reviewed, and still, there are risks associated with the elderly population. I appreciate from my pharmacy colleagues out there in the audience, it's a fine balance between risks and benefits and de-prescribing. I had a lady in clinic with me earlier in the week, and she was in her 90s and she was very active, and we touched on the subject of whether she, the statin, and she was adamant that she wants to remain on the statin, and she wants to be well, and she doesn't want to have any health problems. So I was like, fair enough, so those discussions need to be had. The usual advice is then certainly lifestyle modification that needs to be addressed. We can't just give patients medications, and there's lots of social prescribers out there, health coaches, certainly within the PCN format that we're working under, that can support patients. A lot of patients will prefer to have a chance to make some positive lifestyle changes. And so I think those patients deserve that and need the support to do that. But then it's important to have a clear plan to say, well, let's review this in 3 months, 6 months, depending on what you agree with your patient, and then revisit. Atorvastatin 20 is the guideline recommended high intensity dose. And what we're aiming for is a non-HDL reduction of less than 40% from pre-baseline. And I'll come back to the target levels. There's been a recent change in the actual measurements or the kind of suggested measurements, is that we are now moving away from LDL-C purely to a non-HDL. The rationale behind that is that the non-HDL has been proven to be a better, more accurate predictive risk factor for outcomes, because LDL does not include the very low and intermediate density lipoproteins, neither does it include lipoprotein A. So the NICE guidance and all of that is now set more to non-HDL cholesterol rather than the previous LDL. Particularly, when I did my research into this, I was looking at particularly the non-HDL has got very specific predictory benefits for both men and women. And when they were saying the research suggests that high non-HDL levels compared to normal levels, there's a double the mortality risks in men, and the same, for women, it's 2.5 times mortality risk of a very high non-HDL. So that's a good indication, another discussion to have with your patients. Certainly, this is the national guidance on lipid management in primary and secondary prevention. It's a very useful document. Apologies, I just wanted to kind of show you the document. It is available online. So everything you need to know is in this 2-page document. There is also another one about the statin intolerances, and it gives a real useful information about what to do if patients don't tolerate it, alternative ways that you can try the statins, and certainly monitoring the creatinine kinase, and also if the LFTs are deranged. Very useful documents. Appreciate they are very small, but certainly for those of you running lipid clinics, I would highly recommend have a look at these. Then this is now a very interesting one. This is a screenshot of the NICE patient decision aid tool for a patient with a Q risk of 10%. I feel that these sort of tools are very useful and possibly underutilized. When you ask, certainly when I ask my patients, when they come to see me about, lipid management, this first thing I would say is, you're booked in for your discussion about your raised cholesterol. And then I would turn it around and say, what does that mean to you? What does high cholesterol mean to you? And that is very interesting, the responses you get back. And I would challenge certainly the audience out there, ask your patients, what does it mean to them, high cholesterol? And the answers is insightful. Some would say, oh, well, it's bad. It's like, yes, but why is it bad? Some would say, oh, it's bad for my heart. And then it's really useful to then build on whatever understanding your patient has. And then you'd go into detail and explain, well, you're at high risk of a heart attack and stroke in the next 10 years. And very often the response is, oh, really? This is serious then, So I think we need to in terms of helping our patients understand, yes, there is risks with medication and with statins. Is well documented, well publicized, the potential side effects. But equally, there are risks in not taking the medications. And I think it's important that we really help our patients understand this, because if they don't understand it and they will go, oh, no, I don't want to take the statin, then they don't realize the benefits and equally the risks of taking the medications. And very often a discussion I would have with my patients is people would be happy to take paracetamol that they can buy from any supermarket. And if you look at the leaflet, there's a risk of liver failure, even though it's very small. But patients were happy to take that risks. And it's you need to sometimes spend a bit of time with your patients just to explain that. Another really useful tool I feel and potentially underutilized is the Joint British Society's cardiovascular disease risk calculation, specifically useful for those patients that are keen to make some lifestyle changes in and encourage those. So it's useful to do a baseline assessment, and then you can reevaluate once they come back to you after they've done whatever positive lifestyle changes they were going to implement. And it really, my experience, it encourages patients just to keep going with whatever they're doing and making those small changes that have an impact long-term on their cardiovascular disease risks. Another useful way of looking at targets, certainly to treat your patients, this is from the European Society guidance. They're very clear on what they class as high risk, and they go into a lot of detail around the various associated comorbidities. CKD, your history of a CABG or PCI, and they actually give specific targets for each of these risk categories, specifically around the LDL and the non-HDL levels. And I think this is a good guide, specifically if you have a complex patient, just to give you a little bit more guidance. And they're quite strict when you look at the levels of targets that they want to achieve. So that's why I think it's good that QOF has certainly moved this way to give clinicians out there a specific target. And the other thing is patients, in my experience, like targets. They like numbers. What's my blood pressure? What's my cholesterol like? They want to know these things, and it gives them a focus. They say, right, this is where you need to be. This is where you're at the moment. Certainly, Torvik have mentioned about the statin intensities before. This is a really useful table. This is also included in the previous documents, the statin pathway documents I mentioned before. Essentially, it frustrates me when I see patients on simvastatin 10 milligrams still these days. So atorvastatin 20, anything above a lipid reduction of 40% is classed as a high intensity statin. So certainly when you see patients coming in for reviews, medication reviews, please review the statins that's maybe not as good, and explain to patients that there are better statins out there, more modern, up-to-date statins. Torvik has mentioned about the potential side effects, and it's well known, about the muscle aches and pains. Certainly, I find that it's useful when you commence a statin as have a discussion with your patients about baseline aches and pains. Do they have any problems at the moment? And then when they return with potential problems, it's a useful starting point to say, well, actually, you mentioned that this was a problem in the past. Is it really, any different? Certainly, so those sort of things are worth a discussion. But generally, it is a problem. It can be a problem, and there's also genetic variation where some patients are faster metabolizers, quick metabolizers. These things are worth bearing in mind. Then there's a big thing about the nocebo, or the statin reluctance or statin intolerance, like Torvik mentioned before. Certainly, it's worth checking your thyroid levels as baseline at commencing a statin. Hypothyroidism can be a predisposition for muscle aches and pain, so do be aware of that. And then in terms of the creatine kinase, which I think in primary care is underutilized, again, it's a good indication of is this really related, the muscle aches and pains really related to the statin? Exactly, it gives you a measure of how things are. Appreciate some patients, if it's not bearable, fair enough, but it gives you a good indication of where you can sit and what to do in terms of where you're up to the levels, how bad the symptoms are for the patient, whether you need to try a different statin, leave it off for a bit of time, and exactly, it's a good indication of where you sit. Certainly, statin intolerances is class of having to try at least 3 different statins. Appreciate a lot of patients after the second statin would go, no, I do not want to try another statin. Certainly, one option that is worth considering is intermittent dosing with rosuvastatin. It's certainly off-license use, but it's quite common practice and is mentioned in the national lipid pathway I mentioned earlier. Very often a slow introduction of rosuvastatin twice a week for a couple of weeks, and then possibly alternate days. Patients tolerate it much better. And I have seen cholesterol levels come down on a intermittent dosing like that. Certainly, then we're getting into other things. I know I'll briefly touch on the other statin alternatives, because I know Rosie's arranged another webinar in a few weeks' time about that. But certainly, do not give up if the statin is not working. There are so many different things that we could potentially add to the statin. The ezetimibe is useful, monotherapy as well. But I think the message there really is to aim for the right levels. What we generally say is the guidance up to now was a 40% reduction in non-HDL, but it's really hard, specifically if you're in a busy clinic, signing off laboratory results. What was the baseline? Where are we now? So it is useful to have a target of, as I mentioned, the non-HDL of less than 2.5, or the LDL of less than 1.8. Usually you'd see an improvement in your lipid levels after 3 months. If you don't, it's worth just checking the adherence and see if there is anything else that you could do. Certainly increasing the statin would be an option, swapping to a high intensity statin, and potentially adding in ezetimibe to your statin. So ezetimibe, I'll briefly touch on this in case you are not able to attend the other webinars. It is a very useful option to add into a statin, or when statins are not tolerated as a monotherapy. There is some suggestion that doubling the statin dose is not as effective, and adding in the ezetimibe would be a better option to your statin. And there's lots of evidence to say that ezetimibe actually reduces the LDL-C by 15 to 22%. Bempedoic acid, appreciate there's attendees tonight from all across the Northwest Coast, and I realize that we're all working off slightly different formularies. Certainly in Pan Mersey, this is green on on our formulary here, but it will vary across Lancashire and Cheshire as well. But it's certainly bempedoic acid is worth considering. The only thing is bear in mind reduced renal function and the risk of gout. And then inclisiran, again, there's a lot more detail about inclisiran coming up in future webinars, but it's just worth mentioning that certainly for secondary prevention for patients that do not tolerate statins or are not achieving, this is an option available in primary care. Again, quickly, just some information on inclisiran, but I don't want to spend too much time on that because there's more coming up in very shortly. So overall, I think we need to make sure that statins become our friend, you know, and patients need to understand what's the risks in potentially taking statins, and also the risks of not taking statins or whichever medications. And I think we need to have those discussions and use the tools to help our patients make the right decisions. Thank you very much.